We'll just go directly to Ben Wang, who is also with Dr. Kotanchek and co-chairs the National Materials and Manufacturing Board of the National Academy of Engineering, and he's going to talk about supply chain modeling.
Thank you, Krish. I'm delighted to be here today. So yesterday and today, we have heard different interpretations of the term systems thinking. And what I would like to do is to add a few more to it. From my vantage point as a manufacturing engineer, I think we can look at systems thinking through three different lenses. And the first one is the TRL, MRL, or the technology readiness level, manufacturing readiness level spectrum, going from basic research to representative production environment to pilot production, low rate, full rate, and then the market. So that's one. And the second one was mentioned by Aya, and she had a very good slide to talk about the value chain from the raw materials, fabrication, inspection, packaging, logistics, distribution, all the way to the clinics and patients, and also the long-term monitoring. And then the third one is the stakeholders' view, which Teresa mentioned. We can look at systems as an ecosystem where all the stakeholders work together in an attempt to optimize a set of objectives. And just keep in mind that not all the objectives are aligned across different stakeholders. Okay, so sometimes they are conflicting with one another in terms of the objective optimizations. So that is what makes the decision making interesting. So what I would like to do is to quickly go over a couple of projects and funded by the CMAT's ERC and also BioFab USA. And this is a multidisciplinary approach to addressing the systems issue across different universities, Georgia Tech, University of Wisconsin-Madison, and also University of Pennsylvania, from members of different disciplines. So if you look at the supply chain of the regenerative medicine ecosystems, quite complex. Here I called out the three particular reasons, the three challenges. The first one is it is not an entire pull system, and it is not entirely push system. So it's really the interplays between pull and push are very, very challenging. The second one is if we really want to make regenerative medicine truly personalized medicine, and I think the health conditions of the patient must be taken into consideration during the entire process. Okay, and the third one is, of course, a lot of uncertainties involved, demands, the inevitables such as the machine breakdowns and quality control miss some of the QCs and supply chain disruptions. So digital modeling has become a very efficient and cost-effective approach to looking at the dynamics of the supply chain and the process models. If you look at from left to right, almost the entire value chain, most of the models actually focus only on a narrow band of the activities of the entire value chain. So there are some really critical elements or the tools that are missing here. So what I would like to do is to talk about the supply chain and process models we created, funded by the NSF CMAT ERC and also the BioFab USA, also known as the Advanced Regenerative Medicine Institute. Okay, and then I'm going to show some of the use cases, including capacity planning supply chain disruptions, demand surge, and also cost of goods and automation. So the top level objectives I just covered, the first two, is really to create a decision support platform where different stakeholders can share their perspectives and try to optimize on a set of objectives, sometimes that are not aligned and could be conflicting, in order to have a better supply chain configuration, better control, and better planning. Of course, we develop and we also validate these models using the real world data. And two other important aspects. The one is to inform the standards communities and also to inform the regulatory community, okay, when they develop standards, when they develop regulations for this nascent industry. And then finally, the importance of education and workforce development cannot be overemphasized. So we took a two-pronged approach. So one of them is to develop a very detailed view of a single production facility. It could be a cell manufacturing facility, could be a regenerative medicine, tissue, and organ factories. So look at every processing station, QC stations, human operators, moving vehicles. So from the point where a specimen is collected to the point where a therapy is packaged, inspected, and ready to be shipped. So that is one level. And the other one is to look at the network. Okay, so if you look at, there are three configurations here, but the number of configuration can be very large. So if you look at the one, the bottom left is a centralized production model. For instance, we can build one large factory for the North American market. Or the other end of the spectrum is you look at the lower right, is a point of care where you have a small miniature production facility at every clinic or hospital. Of course, you can have different configurations between the two, which collectively are called the regional hub models. And each hub, okay, may or may not interact with one another. So there's a lot of dynamics in the play. Now, so for the autologous cell manufacturing, this is also is a symbolic representation of the model. And then for the allogeneic cell, okay, so we created another model. This is more of a pushed system, even though it's not entirely pushed. And then the simulation tools that we developed can provide a lot of information for the decision makers, okay? Production situations, utilization of the resources, labors, lead times, quality, and the inventories and ordering status and the failure rates. And what you see here is only a small fraction of all the information that the digital models can provide. So let me start with the first use case. That is the capacity planning. Now, I mentioned the regenerative medicine and cell manufacturing is a nascent industry, unlike aerospace and automotive industry, where they have decades of experience. So capacity planning is very, very important, and is a pressing issue for most of the players in this nascent marketplace. Is how many bioreactors? What's the labor requirements? What sort of level of automation that we should consider over a period of, say, 5, 10, 15 years? So the capacity planning is important. And then we have analytical tools and simulation tools that can help the decision makers or plant managers, okay, to design the best configuration. And the second use case is, what if there is a supply chain disruption? Okay, for instance, a key reagent, all of a sudden, there's a major shortage in the production system somewhere because of the natural disaster or the man-made disasters. Okay, so here in the middle of the screen, you see two lines. One is the blue one. The other one is the orange one. The orange one is when you have a simplified system, one factory and one reagent supplier. So if there's a disruption of 60 days between these two vertical dashed lines, and then you can see without an option, the orange line shows the level of production. It will never go back to the original steady state, okay, because the factory was designed in such a just-in-time or lean production configuration, so there is a lot of backlog. But if you have a second supplier who can provide, say, 50% of the key reagent, follow the blue lines, and then after a certain time period, and then the production will go back to the original steady state. So that's one way to mitigate. And another configuration is where you have two sets of, so one factory with one supplier, and the factory number two has its own suppliers. So if there's a disruption in the factory supplier set one, and then if we can transship some of the production over to factory two, the orders, and then again look at orange, which is the independently operated two systems, or the blue lines is these two set of factories help one another, and then the blue line shows the production can go back to the original steady state, even though after 60 days of disruptions. Okay, so this is another risk mitigation strategy. And the third scenario is a little bit more complicated and quite important. That is, what if there is a huge demand surge, and what do we do? Okay, so there's three different, I guess, risk mitigation policies here in three panels. But the x-axis shows us the level of surge, demand surges. So it could be from the left to right is 2x, 3x, 4x to 5x, okay? And then the y-axis shows the duration of the demand surge, okay, from 20 days all the way up to 50 to 60 days, all right? So the red dots shows the impacts of that particular policies. So let's look at the left panel, accelerated manufacturing. That is when there's a demand surge. And so we have many patients waiting for the therapies. So the accelerated manufacturing is a way to, maybe we cut some of the final inspections, and then we ship the therapies earlier, sooner to the really sick patients. So that's one way to do it. Okay, so you can see this policy is very useful when the demand surge is not as large, but it's independent of the duration of the surge. Now, the panel in the middle, that is labeled priority queue, that is that when there is a surge, many patients are waiting for the therapies, and we try to give the sickest patients the highest priority. And in this policy, you can see that when the surge level is very high, and then this policy becomes very, very effective. And then finally is we do both. Of course, it covers both the low surge and the high surge, and it makes sense. Finally, the final use case is I would like to briefly talk about the way that we look at the automation and also look at the cost. Okay, so there are four different configurations. The two on the left are the manual operations. The upper left is the biosafety and the cabinets, and the lower left is the manual operations with isolator. And then the two on the right, the top one is the biosafety cabinet, and the lower one is automation with isolator systems. So this is the last slide. Okay, so there are several takeaways here. The first one is the manual operations requires really a lot more human labors, and therefore it has a lower throughput than the automated systems. So this one really, it didn't come as a surprise here, okay? And the second one is the isolators. Their initial capital investment is higher, and also more labor intensive than the biosafety cabinet configurations. And then finally, the biosafety with automation, this combination has the lowest unit cost, okay? But the automation with the isolators have the highest throughput, okay? And then across the bottom, we list some of the assumptions that we made when we ran the simulations and modeling. So that's all I had for the workshop today. So Krish, back to you.